My name is Cullen Gibbs, and I've been a neuropsychologist at TIRR Memorial Hermann for about 9.5, almost 10 years now. And what we're going to talk about today is rehabilitation, cognitive rehabilitation, specifically focusing on the executive function, because it's a really important area that a lot of persons with brain injury struggle with. So we'll talk a little bit about that. So we're going to talk about just some basics about traumatic brain injury. We'll also speak a little bit about the relationship between the frontal lobe of our brains and executive functions. We'll talk about what exactly are these executive functions, different areas where you might have deficits, and then some principles for intervention and goals and strategies to address these areas where you may have executive function deficits. So speaking about brain injury in general, I mean, it's sometimes referred to as the silent epidemic, leading cause of death for children and young adults, or death and disability. Persons who survive traumatic brain injury often have academic, behavioral, and other issues that can have a really negative impact on their ability to be successful and to reach their full potential. Sometimes, depending on where somebody is treated and what type of intervention they get following their brain injury, parents may not be aware that there are attention is needed for specific rehabilitation goals and needs. And family members, school personnel, and even medical professionals often have trouble figuring out why a child's behavior or abilities have changed when symptoms appear. So there's a concept of sort of some of these symptoms related to a brain injury may not manifest until a considerable amount of time after the actual injury. So let's briefly go over, what is traumatic brain injury? So basically, what we're talking about is just a physical injury to brain tissue that can result in either temporary or permanent impairment of brain function. We typically think about TBIs in terms of severity, so there's mild, moderate, and severe. We'll talk a little bit more about what each one of those means. So mild traumatic brain injury, or sometimes also referred to as a concussion, is either brief, so less than an hour, or no loss of consciousness, and then maybe some symptoms that go along with that. Moderate, it would be they're having loss of consciousness for about an hour, more than an hour, but less than 24 hours. If there's a neurological evaluation, we find evidence of brain trauma, and there's going to be some positive findings on CT, imaging, or an EEG. Severe brain injury is when a coma lasts greater than 24 hours, and of course you'll also have positive findings on neurological exams. So what happens when a person has a traumatic brain injury? Well, there's going to be structural changes that may be gross or visible or microscopic, not visible. Patients with less severe brain injury may have no structural damage. Clinical manifestation can vary dramatically, depending on a variety of factors. And injuries are most commonly categorized as open or closed. We'll talk about each one of those. So open head injuries are less common. We don't see them as frequently, but they involve the penetration of the scalp and skull. They typically involve, a classic one would be a bullet. It could be any sharp object that penetrates the skull. A skull fracture with an overlying laceration due to a severe blunt force is also considered an open head injury, although something may not have actually penetrated through the skull into the brain tissue. Closed head injury we see much more frequently, and that occurs when the head is struck or strikes an object or is shaken violently. It results in acceleration and deceleration injury, sort of rapid movements of the brain forward and backward that might happen during a car crash, during a bicycle fall, when the head hits the ground, or when a baby is shaken, so shaken baby syndrome, and the baby's necks are not powerful enough to control their the movement of their head, and so they're whiplash effect, and that's what shaken baby syndrome is. So the acceleration or deceleration injuries can injure tissue at the impact, which is called the coup, and at its opposite pole, which is the contra coup. I have an image that talks a little bit about that more. In addition, there can be shearing and rotation injury, which is basically the twisting and rotation of brain tissue, particularly nerve fibers or axons, the myelin sheaths in the brain, that can also result in what's referred to as diffuse brain injury. So here's a graphic that shows exactly what happens sort of with a coup and a contra coup. So this poor fella is getting hit in the head with a baseball bat. So there's going to be a point of injury right there behind the skull where the baseball bat hits. Then there's going to be a tremendous amount of energy that is going to flow through the brain and then move it backwards to slam into the back of the skull, which is the secondary impact of the contra coup injury. So oftentimes in a traumatic brain injury, you're going to have a primary area of damage, where something actually struck another object or was struck by another object, and then on the opposite pole, there will also be damage from that part of the brain slamming into the skull. So what happens in a traumatic brain injury that causes the difficulties that a person might experience? Well, there are some primary factors, so skull fracture, intracranial contusions, hemorrhage, and shear strain injury, what we were just talking about. But then there are some important secondary factors. So we have brain swelling, cerebral edema, elevated intracranial pressure, metabolic crisis, so the metabolic system of the brain gets all out of whack and can cause some significant problems. There may be a lack of oxygen or hypoxia, ischemia, and then there can be mass lesions or a hematoma. And when we think about closed head injuries, the cranial vault is, it's very confined, and it's designed to be that way to protect our brain. The problem is when there is swelling of the brain, it has nowhere to expand. And so that increases the intracranial pressure significantly and can can be fatal when the brain begins to herniate and push down into the brainstem area, which is responsible for respiration and other vital functions. So there's also the neurochemical aspects of this, which is excessive production of free radicals, excessive release of excitatory neurotransmitters, and then disruption of the cellular calcium homeostasis, which is then related to some of these delayed effects: white matter degeneration, cerebral atrophy, or just shrinking of the brain tissue, post-traumatic hydrocephalus. If the cerebral spinal fluid is blocked in any way, shape, or form, then it will cause excess water in the brain, which also increases intracranial pressure, and post-traumatic seizures. So when a person has a traumatic brain injury, they are much more vulnerable to having seizures. And it's not uncommon that, either at the scene or en route to the hospital, that they may have a seizure along the way. So let's talk a little bit about frontal lobes and executive function. So whenever somebody has a traumatic brain injury, we're always going to be thinking about damage to the frontal and temporal regions, regardless of the pathophysiology. And that's because, the frontal lobes are situated as such. It's a large area at the front of our brains, behind our forehead, and going backwards to the posterior, and they're vulnerable to injury. They just sit in a place that is vulnerable to injury from striking your head, falling forward, for instance, or striking your head on something in a car accident. And there's also some bony prominences in the skull, beneath the frontal lobes that can cause hemorrhaging and that kind of thing. It's vulnerable to traumatic brain injury. We understand, and we've understood for quite some time, that there are well-known associations between frontal lobe and executive functions. And executive function deficits are very common after childhood TBI and adult TBI, but particularly for the purposes here for childhood TBI. So some of you may know the story of Phineas Gage, which is an early 19th century incident that helped people really understand the importance of the frontal lobes and behavior. So poor Phineas was a railroad foreman, and he was working on clearing rock for a railroad track, and what they would do is they would drill holes into the rock, and they would place dynamite charges in the holes, and then ignite the dynamite charges and clear the rock. Well, they used these tamping irons, he's holding in his hand there, to push the dynamite into the hole that was drilled. And a spark or something happened when he did it. And so the dynamite exploded, and then the tamping iron shot out like a projectile, like a missile, and went through his left cheek and straight out of the top of his head. So it's a pretty gruesome injury, and there were people around there to witness the accident. And of course, this is middle 19th century. There's not a lot of good medical care, certainly ambulances and that kind of thing. I believe he was in rural Massachusetts. But they collected him, put him on a wagon to take him to a doctor. He did lose consciousness. But what was amazing is that not long after the incident occurred, he was alert and conscious, and he was talking, and he was able to recall sort of what happened right before the incident, and he seemed pretty normal. But later on, as time went on, people began to notice that there was a significant change in his behavior. They described it as Gage was no longer Gage. He became much more impulsive. He had a hard time controlling his emotions and controlling his behavior, saying inappropriate things, doing inappropriate things. Although he knew everything that he knew before related to his previous job and everything that he had learned prior, he was able to use that knowledge in order to actually function successfully and carry a job or maintain employment. And so what we understood is that the tamping iron went through the sort of the orbital and very prefrontal cortex right at the front of the brain, which is an area that is critical for underlies these executive functions. And so that helped people understand sort of the critical role of that part of the brain to the ability to control cognition and emotions. So what are the executive functions? They've been defined in a variety of different ways. Here's a couple of different definitions. But basically, if you look at what's similar here, we're talking about skills that are related for goal-directed, purposeful kind of behavior. Things that are related to somebody being able to be independent in their daily activities. And so that's a very sort of broad area to think about, but once again, I think if we just sort of boil it down, purposeful, goal-directed behavior. That's kind of what the executive functions are responsible for, or what they allow us to do. So there are a lot of analogies that you can use for understanding the role of the executive. So the conductor of the orchestra, the CEO of the corporation, the general of the army, or the head coach of the team. So that's kind of what the role of the executive functions are with all of our other cognitive processes. They kind of lead and guide those processes to implement goal-directed behavior. So we're going to kind of go with the conductor of the orchestra analogy. So what is the functions of the conductor? So, thinking about the executive functions as a conductor, it helps a person initiate goal-directed behavior, to get started on something independently, working memory or a person's ability to hold information in their mind in order to complete a task, things related to planning and organizing, so more complex multiple-step tasks or tasks that require management of a lot of individual details. It involves the ability to self-monitor or be aware of our own behavior, to know when we're saying something inappropriate, that kind of thing, to inhibit or to not respond impulsively. And then flexibility, so if something we're doing doesn't work, can we think of a way to do it differently? If plans change, can we adapt flexibly to meet those changing demands? Emotion regulation, so can we manage our emotions so that little things don't result in a big emotional outburst? And then self-awareness. Do we understand, or are we aware that there's something different about us, that we have some difficulties? So here are just some definitions that talk a little bit more about each one of those areas. But once again, these are all very important in purposeful, goal-directed behavior. So what's the orchestra? So when we talk about the orchestra, so these are sort of the processes that the executive is kind of in control of. So basic perception, auditory visual perception, conceptual thinking, so the ability to form concepts, more sort of like abstract thought, language processes, so ability to organize thoughts to express them clearly, visual spatial processes, memory, so the ability to remember new information and to retrieve information from memory, sensory inputs, smell, sound, sight, all of those kinds of things, motor outputs, so being able to carry out some sort of consecutive motor behavior, emotion, and then knowledge and skills in general, everything that we've learned in the past that are related to social interactions and non-social interactions. So that's kind of the orchestra. And so there's a relationship between the functions of the conductor and the functions of the orchestra. So the sort of the feedback going between these processes, and if the processes of the conductor are not working appropriately because of traumatic brain injury, then these other processes are not going to function appropriately either. So what do the executive functions do for us? Well, they help us provide for delayed responding. So if somebody puts the cookie on the table, not immediately grabbing the cookie and eating it, to be future oriented, to think about something beyond right now, the present moment, to be strategic, to choose a deliberate plan of action or process, to anticipate what might occur depending on the situation or the context we're in and what our decisions will be. Freedom from interference, so every little sound, light, noise, what have you, won't distract us from what we're trying to do. And then the ability to sequence behavioral output, so being able to put things in a correct order so that we can complete a task or an activity. So what are the situations where we have high demands on executive functions? Well, there are a variety, but basically we can think any situation or any task that requires multi-step tasks and learning, puts a high demand on executive functions. Novelty, so basically something that is unfamiliar, that you have no experience with, versus something that's automatic. Automatic behaviors, or something that's well learned, can often be performed very easily by a person with a brain injury, but it's the new unfamiliar tasks that cause more stress and frustration. So then thinking about high stress situations, so high stress, whatever that might be, is going to put a lot more demands on executive functions. Future versus present orientation, so being able to think about the future and consider the results of our actions. And then, being able to intentional action selection, so when we have to think about, being cognizant of what our actions and processes will be. And so anytime there is one of these factors going on, then it's going to definitely require different aspects of executive function. And if those executive functions aren't functioning in a way that provides the appropriate support, then these things are going to cause a lot of frustration and difficulty. We have good executive function. We have purposeful, goal-directed, like we were talking about in the definitions. Active problem solving, good self-control. You can wait and not pick up the cookie. Can be independent. Can be reliable, counted on, consistent. Positive self-efficacy, feeling good about yourself, feeling that you can accomplish tasks independently. Internal locus of control, feeling that you can, that what happens in your life can be based upon your actions in the world as opposed to controlled by the actions of others. So when we think about executive function to other areas of functioning, so basically if somebody has executive function deficits, well, it can really impact language-based problem solving, things related to reading and writing because of demands on working memory and organization. Oftentimes, like for instance, reading comprehension might be something that's much more difficult. If the child has already learned how to read, sight word reading, that kind of thing, no problem. But comprehending what they need to read, being able to, answer questions about like what's the main idea or that kind of thing can be much more challenging. And of course, writing, being able to organize the thoughts in a way so that you can write a coherent composition or that kind of thing can be very challenging. Nonverbal problem solving, definitely is related to a person's ability to deal with new situations, unfamiliar situations, and is going to put heavy demands on organization and flexibility. And then finally, communication problems. Being able to organize your thoughts, being able to not say what immediately comes to mind, if that is inappropriate. And kind of remembering where you are in your train of thought when you're talking. So how do we identify executive function deficits? So executive function is dynamic, it's fluid, it's definitely an area, there's multiple components of what we're looking for. In everyday life, the executive role is often provided by the examiner in a testing situation, family members at home, or just a lot of structure in the environment. Tests, formal tests and informal tests are multidimensional. They require both content knowledge and executive function. We should see executive function difficulties across domains, so like we were talking about, it can impact language, it can impact nonverbal problem solving. We also need measures of a client's real-world expression of executive dysfunction. So how does this look in everyday life? There really isn't a single test of executive function. There are a variety of different tests that are used. Oftentimes, some of these are based on indirect observation. You're making inferences. IQ tests are not typically a good measure of executive function because they're more structured. They rely on the acquisition of prior information and that kind of thing. So we have a variety of different tests. So we have these sort of micro-level tests so that look at very specific processes, working memory, response inhibition, or not responding impulsively, organization, flexibility. These are like tests that we would give where a child's performance would be compared to other children their age. Then there is sort of the macro level test, which is looking at everyday behavior and performance in context. So this would be behavior ratings, where a parent is answering questions about a child's executive function in everyday life, or just sort of observing the child in the natural context, such as home or classroom or that kind of thing. And so oftentimes the macro level is where it's really important, because sometimes persons with executive function deficits can perform okay on some of these specific process tasks, but their ability to demonstrate that skill in everyday life is diminished significantly. So we want to have both. We want to have the micro level and the macro level. So when we're talking about intervening with executive function, there's some different principles we want to keep in mind. So one is having a good assessment or an evaluation where they're going to be able to define what the nature of the executive function deficit is, and how is that associated with other skills and abilities. Determine the overall functioning level of a person and what's appropriate expectations for executive function based upon that. Also important to consider, where a person is developmentally in terms of age expected executive function behaviors. So then we think about intervention. So with intervention, basically what we're talking about is helping a child by teaching goal-directed problem-solving process. So a goal-directed problem-solving process. And doing this within everyday meaningful routines, sort of, getting ready in the morning, doing homework, working on a project in school. Things that developing these goal-directed problem-solving processes for situations that have real-world relevance and application, kind of where the rubber hits the road, so to speak. And then using key people to sort of serve as models or coaches for implementing these goal-directed problem-solving processes. And so that is an important component. So we're talking about sort of going from an external to an internal process. So we start off with external models of multi-step problem-solving routines. External models meaning, maybe something that is a piece of paper that has a routine on it. External models, an adult showing the child how to work through that routine using that process. In that process, we're going to be providing guidance to develop and implement this process in everyday routines, provide practice in the application of that, and in the use of routines, and then gradually fade the external support to cueing and internal generation of the use of the routines. So, at the beginning, it requires a lot of modeling, a lot of hands-on, a lot of external support. But over time, the idea is that with repetition, that these routines become internalized and more automatic. So when things are becoming more internal, so that means that they're going to be able to generate and use a specific problem-solving routine, generalize that to a new situation, accumulate experience and examine conditions for when to use various routines, and then feedback throughout. So here's some examples of what we're talking about with routines or processes for supporting executive function. So one we'll talk about a little bit more: goal, plan, do, review. It's sort of an everyday routine that can be used for going through a problem or a complicated task in a very systematic way. Supporting working memory via a hard copy of the routine. So we're not going to expect the child to hold that information in their mind, but we're going to have it written down so that they can refer to it. And then allowing the child to become increasingly more active in formulating plans and reviewing their performance. So here is an example of that, and one of my favorites by Mark Olfazacher and Tom Feeney. Goal, plan, do, review. And so if you notice, at each step here, there is a question that the child is going to be asking themselves, right? So it's sort of metacognitive, thinking about your own thinking. So, starting off as, what am I trying to do here? Where am I going? What's my goal? Because if you're not starting in the right place, then everything is, not worth the effort. Then next would be a plan. So how am I going to accomplish this goal? I know what my goal is, now how am I going to do that? So, and thinking about what are the materials that I need, the equipment, and then what are the steps involved in doing this. Then we kind of get to this sort of self-awareness kind of area. Prediction, how well will I do? I can rate myself from a 1 to 10, 10 being I'm going to do great, 1 being I'm going to do terrible, and then whoever's working with us, parent, teacher, would then say, you said you're going to do a 10, but I think this might be tricky, I'm going to give you a 3. And then how much will I get done? So that would be either all of it, maybe steps 1 through 3 or that kind of thing. Then you actually, once you've done that, you implement that problem-solving strategy. Even with a good, a really good solid plan, there's going to occasionally problems will occur. So keeping track of those problems and generating solutions. Then once you've done that and the task is complete, you review. How did I do? I said earlier that I thought it was going to be really easy. I said that I thought I would get a 10, but thinking about it now, it was a little harder. I got a 5. I'm going to give myself a 5, and then it allows the teacher, the parent, to also do a rating and provide some conversation to hopefully improve accuracy in terms of assessing performance. And then finally, at the end, asking these questions: what worked, what went well, and what didn't work? What would we do differently next time? And this is a flexible process that could be used for a variety of different tasks. For instance, cleaning a room, writing a paper in school, or planning for a project. It could be used for a variety of different tasks or activities. And this would be sort of an external, hard copy of that routine that a person could refer to, and at the beginning, having these things demonstrated or assisted by an adult or the parent, the teacher, the coach. And then with repetition of this, gradually the idea is that this process becomes internalized, and it's sort of the natural way that the child goes about their problem-solving process. So sometimes there isn't a really good focus on executive functions and rehabilitation, and so sometimes that's because people think about these as higher order sort of skills, and we don't want to start there until these lower order kind of cognitive and social processes are developed or treated, and there's really no evidence to support that. Sometimes it's a desire to protect the individual, resulting in family or care providers assuming responsibility for all executive aspects of an individual's behavior. So a lot of times, and it's natural and understandable, but a parent will sort of take on the role of the executive, right? And then the child has no demands in this area, and so they're not going to improve in their ability to demonstrate these skills independently. So that's kind of goes into a little bit more about that, but we want to be sure that we don't want to have parents as frontal lobes for the brain injury patient. We want hopefully to allow the patient to develop some of these skills so that they can be more independent in their behavior and their environment. Also, sometimes there may, depending on who the professional is who's providing the rehabilitation, there may be a lack of focus on executive function in training programs. So it's just not something that occurs to somebody to focus on. Another issue is that sometimes, a child with a brain injury can give the appearance of being in control, but in familiar, structured kind of situations where they can rely on previously learned skills and knowledge, these well-established routines, so they may not be as apparent. And so that could be another reason that it would not be addressed early. happens if we don't think about executive function? With luck, the child's going to develop some sporadic independent problem-solving skills. What's more likely to happen is that there's going to be learned helplessness, there's going to be dependency on others, and then with that dependency, there's going to be increased oppositional behaviors because it's frustrating to have to be dependent on someone. All right, so we're almost out of time, 3 minutes. So when we think about executive function intervention, we want to think about it across contexts. It has to kind of occur in a variety of different settings. So we want to coordinate between different therapies and environments. Therapy, for instance, therapy at home, therapy in school. Recognize common executive routines between settings. Use similar strategies. So for instance, the goal plan, do review. Use of common executive function routines notebook, so you can have a notebook that has different routines for different situations. And then of course communication between all the people responsible for the child's intervention. What is executive function intervention is not a specific set of skills or information to just kind of teach. It's not something that they're just going to memorize. It's something that they have to utilize. It's not simply just a list of steps, take to the bathroom mirror. It's not just rewards or motivation to increase motivation, or it's not something that's just focused on the child without paying attention to the importance of how, who, where, and when this kind of intervention is going to be delivered. So I'll run through these really quickly, but so here are some, ideas or strategies for supporting some of these specific executive function deficits. So initiating basically is when a child has a hard time getting started, even when they know what they're supposed to do. And so here is some strategies for helping with initiation. A good one is breaking tasks into small manageable steps. Sometimes the person can be overwhelmed, they don't know where to start. Important as well, reframe lack of motivation as an initiation deficit. So oftentimes, it's not that the person isn't motivated, but they don't know where to start. They don't know how to start. So sustaining effort, having sort of more salient, interesting tasks that they're working on, more hands-on, that kind of thing. Working memory, repeating instructions as needed, quietly, keeping instructions clear and concise, having a reference, maybe something written that they can refer to, and having a script for whatever the issue may be. Not responding impulsively, so certainly structure helps a lot of that. Having clear expectations, having clear rules, and then teaching response delay techniques, so counting before 10 before acting and that kind of thing. Shifting, once again, increased routine helps. Schedule, have a clear schedule, giving a 2-minute warning, which a lot of us do with our kids, that kind of thing, can help them shift from one activity to another. Organizing, so just having an organized environment is an important part. Being organized in the therapy process, the teaching process is important. Present the framework for new information at the beginning, and begin with tasks that only have a few steps and then increase it incrementally. Planning, so tasks that require just a few steps at first, having a flow chart, practice with planning tasks, and sort of having a conversation with the child about what happens if this plan doesn't work, what are the consequences of this plan if we implement it, that kind of thing. So these things can also be applied to an individual education plan or to a treatment plan for like a physical therapist, occupational therapist, or speech therapist, written as specific goals. So I'll just go through. Here's an example. With directed assistance, Johnny or Jenny will. So that's kind of the first part of the goal. And so like for instance, goal setting. The client will participate with therapists in setting instructional goals. So for instance, I want to be able to read a book. So, and the child is working on this. Planning. Given a routine, cleaning room, hygiene, whatever, the child will be able to indicate what steps or items are needed and the order of events. Organizing. The child will follow or create a system for organizing personal items in his locker. Kids don't really use those anymore, but maybe backpack, for instance. Self-monitoring. The client will keep a journal, will identify errors in their work without assistance, that kind of thing. Self-awareness. The client will accurately identify strengths and weaknesses. Self-initiating. When the client doesn't know what to do, he will ask for help. With ADLs, it could be written statement of the client's goal for getting more independent in dressing or whatever it might be, and similar process involved. All right, thank you. Just 3 minutes longer. Any questions or follow-up? All right, thank you very much. Have a good day.